Good evening and welcome everyone for today's NCSI webinar. Uh, I will hand over it to Dr. Varun who will be coordinating the session today. Over to you, Dr. Varun.
Hi, so good evening, everyone. So, all the listeners who are viewing this. So, this is an interesting topic which we always present the problem based learning for the residents from Neurocritical Care Society of India. So, today's topic will be presented by Dr. Mayank Tyagi. He is consultant in Department of Neuroanesthesia and Neurocritical Care at Fortis Hospital, Noida. And as an expert, we have with us Dr. Jyoti Bala. Ma'am is a senior neurologist. She is director and head of Department of Neurology at Fortis Hospital, Noida. So, I will just go ahead with this case. So, this was a case of acute non-traumatic progressive weakness. It was ascending paralysis, and we had a diagnostic dilemma while dealing with this case, and there were many challenges which we faced. So we'll be going to present this case. I welcome Dr. Mayank to start with the case. So,
Thank you,
Dr.
sir.
Mayank, let's.
Sure. Thank you, sir. A warm greeting to all my seniors, my juniors, and my colleagues. Let's delve into this intriguing case. I hope you will find it interesting. On day one, Mr. NR, 37-year male, brought to our hospital with complaints of fever from last 5 days, accompanied by sore throat and body pain, bilateral lower limb weakness since 4 days, imbalance from last 3 days. The patient appeared asymptomatic until 6 days back when they reported experiencing a tingling and sensation in both lower limb, more pronounced in the right leg than the left. Gradually, weakness developed in the legs and continued to worsen, accompanied by a sense of imbalance. He doesn't have any history of hypertension, diabetes, or hypothyroidism. There is no history of headache, vomiting, confusion, visual disturbances, seizure, migraine, trauma, chest or back pain, slurring of speech, weight loss, anorexia, arthralgia, myalgia, fatigue, diarrhea, double vision, abdominal pain, skin rash, polyuria or polydipsia, and weight loss or fatigable weakness in the eyelids. There is no history of drug intake, addiction, toxin exposure, insecticide exposure, alcohol, or smoking. There is no history of surgery, infection, trauma, psychiatric illness. He is non alcoholic and non smoker.
So, here Dr. Mayank has given a very detailed negative history, and he'll be throwing light on why we have taken such a detailed negative history, which will become clearer in the later part of the presentation. Going ahead.
This patient had a history of dog bite in the right leg in May 2025, for which he took 3 rabies post exposure prophylaxis vaccine. He arrived in the hospital with Glasgow Coma scale of 15 by 15, with pupil bilateral 2 normal reacting to light. On motor assessment, power was 2 by 5 in the lower limb and 4 by 5 in the upper limb, with a Medical Research Council score of 40 in the with presentation of proximal weakness. He is able to perceive touch, pain, temperature, vibration, and proprioception. That means the sensory assessment was normal at presentation. Deep tendon reflexes were decreased. There is no bladder and bowel involvement. Single breath count was 14, and all the blood investigations were appear to be normal except for serum sodium, which was 128 millimole per liter.
So at this point of time, something which was more interesting was that the patient was a little tachypneic. Respiratory rate was around 25 to 30 with the lower limb weakness, which is there. But patient was maintaining saturation at this point of time.
So, Dr. Varun, do we have
Exactly.
residents in this audience?
Yes, ma'am. Residents are going to be there. It is live, so they will be able to view it
Okay,
later.
so we can ask them the possibilities they would think of based on history.
Ma'am. So the
They could,
questions will keep popping up, and if there are any questions, we will answer those questions.
okay, all right.
So outside dengue, NS1, malaria, typhoid, and viral tests were negative. So we made a provisional diagnosis of Guillain-Barré
GPS.
syndrome, bulbar involvement.
Mm. So, So, because this was a non-traumatic weakness, and non-traumatic weakness, if it is ascending, it can be very life-threatening to trivial disorders. It could be just electrolyte imbalance, which could be there, and this requires a synchronous resuscitation and workup at the same time. So, initial neurological examination, which has been done previously, it is necessary to rule out the critical time-sensitive emergencies, especially with regards to stroke, and also to ensure scene safety, like if there is toxic exposure. So, relevant investigations and imaging they should be done later on, as we'll come to it. And so, Dr. Mayank will now highlight the approach which is necessary in case of a ascending paralysis to localize the lesion.
So this is a graphical representation showing whenever the patient is brought to the management of the cases, for showing whenever the patient is appeared in the ER or neuro ICU with acute non-traumatic weakness, it is extremely important to establish last known well to be time and date for time sensitive diagnosis and treatment purposes, especially in etiological emergencies like acute ischemic stroke, CSS infections, status epilepticus, spinal cord compression, aortic dissection, dyselectrolytemia, or toxins. We will establish affected anatomical region. We will assess airway, breathing, circulation, and sugar checkups as mostly patients with neurological illness present patients need airway protection and ventilation if their airway is at risk of aspiration or breathing is inadequate. We will perform a comprehensive neurological examination, which we'll discuss in the further slides. And we will also localize the area based on clinical or anatomical region, like in whether it depends on the upper motor neuron or the lower motor neuron involvement. Further on, we will create an initial working diagnosis and we will send battery of investigation and obtain a relevant NCT imaging. Now, this is a mind map showing comprehensive neurological examination and categorizing such patients based on clinical localization, based on upper motor neuron or neuromuscular junction, anterior horn or muscle group, based on clinical symptoms, whether it is sensory or motor, or whether there is any cranial nerve involvement is there or not. Sensory and motor involvement, lateralization, pattern of weakness, whether it is ascending, descending, or asymmetrical, and reflex status based on whether it is hyporeflexia, hyper, or there is areflexia. Now, we will discuss each disease one by one and we will make a diagnosis for our case. Mostly patients with acute stroke, subarachnoid hemorrhage, intracranial mass, or any spinal cord lesions generally present with history of trauma, hypertension, raised intracranial pressure changes like nausea, vomiting, blurring of vision, which is not seen in our patients. So these four diagnoses has been ruled out from our study. Patient, our patient doesn't present it with hypoglycemia or hyperglycemia. There is no history of seizure, migraine, or trauma, or any neurological examination showing contralateral joint vibration or proprioception loose or ipsilateral muscle weakness. So Brown Sequard syndrome and other four diagnoses has also been ruled out. There is no history or clinical examination based on asymmetrical pain in the hip, buttock, thigh, or any association with poor glycemic control. So acute diabetic lumbosacral neuropathy is also being ruled out. There is no involvement of asymmetrical progression of paralysis. So acute West Nile fever and Japanese encephalitis virus is also being ruled out. There is chances of pleocytosis in both these diseases, but we will discuss it later in the slides. Patients with ALS generally presents with hyperreflexia, also manifest with slurring of speech and dysphagia, which is not seen in our case. And patients with poliomyelitis generally present with hyperreflexia, but it is noted that these patients have generally asymmetrical pattern of weakness. So both ALS and poliomyelitis is ruled out from our study. Generally, patients with vasculitic neuropathy present with weight loss, anorexia, fatigue, arthralgia, myalgia, and flaccid asymmetrical paresis, which is not seen in our patients, so it is ruled out. Patients with stocking and glove sensory loss, along with distal weakness, is seen in toxin induced peripheral neuropathies and nerve compression syndrome. So, this has also been ruled out from our case. Coming down to neuromuscular junction localization, there is no descending asymmetrical paralysis, diplopia, nystagmus, or ptosis in our patient. There is no tick found attached to the patient. There is no history of insecticide exposure, so all above three is being ruled out. There is no involvement of eyelid extraocular muscles resulting in ptosis or history of fatigability. So myasthenia gravis has also been ruled out from our case. Coming down to muscular group, there is no characteristic heliotropic rash appearance or systemic manifestations like arthralgia or arthritis in our case. So, muscle group is also being ruled out from our localization.
So at this point, I would like to ask Dr. Jyoti. Ma'am, so we have ruled out quite a few things over here. And so our differential diagnosis at this point is Guillain-Barré syndrome. Are you like convinced with
Yeah,
this thought at this point of time,
yeah.
based on the history?
Actually, from neurological perspective, if any patient presents with acute flaccid weakness or quadriparesis, so we have only few differential diagnoses in mind. One, of course, is GBS. Then we have porphyria. We think about porphyria, and we think about transverse myelitis because when cord is in shock, so one may get element type of picture in the beginning. So these are few differentials which we consider when we are dealing with this, but it's good that he has elaborated all diagnosis because some
Detailed,
of the
yes.
diagnosis, yes, detailed
Hmm.
in detail, because some of the diagnosis like ALS and polymyositis and poliomyelitis, we generally do not consider in any patient who presents acutely.
Exactly.
But for the sake of
Correct.
residence,
Correct.
it's good that he has enumerated all diagnostic differentials.
Okay. Okay. Thank you, ma'am. So, going ahead with our case, so Mang, as we have already highlighted that the patient was a little bit tachyphonic, so respiratory rate was around 25 and 30. He was a bit breathless while speaking, but he was
Right.
maintaining saturation. So,
Right.
are there any specific conditions in which, or at different stages, when you would like the patient to secure the airway of the patient and intubate this patient?
Absolutely. Uh, we can divide it into clinical and objective symptoms. Clinically, uh, such patients who require mechanical ventilation support the indications might be severe tachypnea, single breath count of less than 15, inadequate chest rise, paradoxical respiratory pattern, use of accessory muscles of respiration, rapid progression of weakness, breathlessness at rest or during talking, severe autonomic dysfunction, unable to remove secretion from the throat. That is important. That is involvement of severe bulbar
Involvement.
involvement.
Here, I
Objectively,
would like to just add to it, Dr. Mayank, that this is very important indication. Once you have all these signs and you are suspecting GBS, that is an indication for starting
right,
IVIG in such patients.
absolutely, ma'am.
Yes, so when the our patient presented, we felt like he was pulling some secretions, and during speaking, we could sense that there was some gurgling sounds which are coming. So we were a bit worried in this case.
Yes.
Going ahead.
Objectively, if there is any loss of consciousness, if there is any vital capacity of less than 15 to 20 ml per kg, maximum inspiratory pressure of less than minus 30 centimeter H2O, maximum expiratory pressure of less than 40 centimeter H2O, abnormal ABG findings or EGRI score of more than 10, then there becomes an indication for intubation and mechanical ventilation support.
So
So
can you
what is
highlight about the IGRIS score? Hmm.
Yes. EGRI score is basically Erasmus GBS respiratory insufficiency score. It is a prognostic tool which calculates the probability that a patient will require ventilation within 1 week of assessment. It is categorized into three uh, zones. One is days between onset of weakness and hospital admission. Second, facial or bulbar weakness at the time of hospital admission. Third is the medical research counseling, uh, some score at hospital admission. It is basically a measure of global peripheral muscle strength, which ranges from 0 to 60. And up to 22% of the patients with GBS require mechanical ventilation support within 1 week of admission, as per the study published in 2010 Annals of Neurology.
Okay. So going ahead with our case.
So, based on patient clinical history and examination, a preliminary diagnosis of GBS was made and planned to
Hmm.
start IVIG empirically.
Okay. So, what are the different variants of GPS? Can you just quickly highlight like the few variants of GPS which can be there?
Sure. The two most common variants for GBS is Amsan time, which is classical sensory motor GBS, which accounts for 30 to 85% of the cases. And second is Aman type, which is pure motor, which accounts for 5 to 70% of the cases. The most rarer one is the Asan type, which is pure sensory type. The other being paraparetic, pharyngeal, cervical brachial, bilateral facial palsy with paresthesia. Apart from those, the other two variants are Miller Fisher and Bickerstaff brainstem encephalitis, but they are different from the diagnostic criteria of GBS, which involve ophthalmoplegia, ataxia, areflexia, pyramidal signs, and impaired consciousness. Now, this is the graphical representation of the pattern of symptoms typically observed in different clinical variants of GBS.
So, here I would like to ask Dr. Jyoti ma'am. Ma'am, so you are suspecting a classical GPS over here or some other variant?
In this patient, we were suspecting classical variant only because he presented, I think, 4 days or 3 days into illness when he presented to us. And they classically presented with sensory involvement and weakness of lower limbs. So we were expecting that this is an ascending kind of paralysis. So lower limb have been involved, and now there will be involvement of the upper limbs. And there was already cranial bulbar involvement. So this was a kind of classical variant which was present in this particular case.
Okay. Okay. So, Dr. Man, what are the diagnostic criteria for GPS?
Sure. As per the National Institute of Neurological Disorders and Stroke, 1990, the features which are required for diagnosis of GBS are progressive bilateral weakness of arm and legs, absent or decreased tendon reflexes in the affected limbs. Feature that strongly support diagnosis are progressive phase that lasts from days to 4 weeks, relative symmetry of symptoms and signs, relatively mild sensory symptoms and signs, cranial nerve involvement, especially bilateral facial palsy, autonomic dysfunction, muscular, radicular, back or limb pain, abnormal albumin-cytological dissociation, electro-diagnostic features of motor and sensory motor neuropathies. Features that cast doubt on diagnosis of GBS are fever at onset, nudge less than 24 hours, abdominal pain, pleocytosis in CSF, persistent asymmetry of weakness, bladder or bowel dysfunction at onset, severe respiratory dysfunction at onset, hyperreflexia or extensive plantar responsive, sensory signs with limited weakness at onset, continued progression for more than 4 weeks, or alteration of consciousness.
Okay. So, so going ahead with the case, uh, how did you manage the case further?
A central venous catheter and an arterial line were inserted, and we took the consent for intubation and mechanical ventilation support.
Okay, so what was the reason for securing an arterial line in this case?
Actually, it provides a real-time, accurate blood pressure measurement, which is crucial in critically ill patients who may experience fluctuations in blood pressure due to autonomic dysfunction, which is a common feature in GBS patients. It also allows quick modification to treatment, such as fluid management or medication management. Regular assessment of blood gases can be done through arterial line.
Yes,
And
ABG assessment becomes.
another
Yes,
benefit
ma'am.
is like, yes, another benefit is like some of these patients may not respond to IVIG. You might have to consider flex. So you can
Right.
ensure hemodynamic stability during flex
Mm,
Right.
with the arterial line.
correct, correct. And you rightly mentioned about the frequent ABGs which are needed, and that is also troubling for the patient.
Right.
Okay. So, can you just highlight what are the treatment modalities which are available for the management of GPS in brief? Because those have been covered in various seminars previously.
We have two treatment options for such patients. One is IVIG, which is given in the dose of zero point 0.4 gram per kg body weight daily for 5 days. And another one is plasma exchange, which is given in the dose of 200 to 250 ml plasma per kg body weight in 5 sessions.
So, just highlight the advantages and something to be cautious about when using the IVIG and plasmapheresis.
The advantages related to IVIG being it is easier to administer. It can be given through IV infusion, lower risk of complications, faster to initiate treatment as compared to PLEX. It is useful in low resource centers, better tolerated by children, pregnant females, breastfeeding, and elderly patients. The disadvantages being maybe less effective if started late after 2 weeks. There are certain risk of renal dysfunction, especially in patients with pre-existing renal diseases.
And about plasmapheresis.
The benefits and potential drawbacks for Plex being the advantages are it directly removes circulating antibodies and immune complexes. It is effective in centers with apheresis facility. The disadvantages being it's being a invasive procedure, so catheter related complications are always here. Not ideal for patients in hemodynamically instability or with those with bleeding diathesis. Risk of hypotension, hypokalemia, hypocalcemia, coagulopathy, allergic reactions, and infections are always there. And it requires specialized equipment and trained personnel.
So, at this point, I would like to ask Dr. Jyoti, ma'am, your
Yes.
take on this is one thing better over the another, and
Dr.
your
Mayank,
preference at
first,
our institute.
yes, yes, I completely agree with Dr. Mayank. Like, though plasmapheresis is little faster acting, but definitely you have to ensure hemodynamic stability.
Right.
Given the choice between the two, my preference, personal preference, is IVIG because it is easy to administer. You don't have to insert line, and you don't have to worry about hemodynamic stability. But there are times when patients do not respond so well to IVIG, and when there is rapid progression, when we need faster results, those are the cases where sometimes you have to consider PLEX because you get faster results. If you are able to prevent these patients from ventilatory support, then that definitely improves their prognosis. So another thing is like there are times when you feel that IVIG has not worked for them. What next? So we have to combine Plex with plasma with IVIG. There was a old school of thought that once you have given IVIG, you cannot do the Plex, but it is not true. Once you have given IVIG, IVIG is larger molecule. It does not get filtered with plasmapheresis. If you feel that response is suboptimal, patient's weakness is rapidly progressive despite giving IVIG, you can combine the two.
Okay, okay, okay. So we'll continue with our case, and ma'am, how did we proceed further?
There were some red flag signs and symptoms in our case. One is fever at onset, and drowsiness in the patient, which is not
Okay.
pertaining to GBS patient. So we planned for a lumbar puncture in this patient after obtaining a written informed consent.
Okay.
So,
So,
so, Dr. Mayank, generally we do lumbar puncture in the second week, right? In this
Right,
particular case, these were the
right,
red flags, so that was the reason we did the lumbar
right,
puncture in first week itself.
right.
Because if you do it in first week, you may not get those particular findings which you expect in
Mostly, there
GBS.
will no psychological dissociation is not fine in most
Yes,
of the cases during 1 week, during
yes,
the first week.
yes. But here the indication was different. There were some red
Right.
flags.
okay. So, these were our findings. So, can you just enumerate?
So the immediate contraindications or consideration for performing a lumbar puncture without
No,
first
my
opinion.
CSF findings.
Right. So
Okay.
the
Hmm.
CSF findings in this case was there is pleocytosis with raised protein counts with predominance of lymphomononuclear cells, and we have also sent CSF biofire for comprehensive meningitic and encephalitis panel, which was not detected in our case.
Okay. So, the biofire came out to be in negative.
Negative.
So, uh, ma'am, do we send biofire routinely in case of GBS? Or if we are suspecting meningitis, then only we consider sending a biofire because it is
Generally, we
like
do
costly.
not send biofire in cases where we have classical finding of cytoalbumin dissociation in GBS. If cells are not there, only protein is elevated, we don't suspect any infection. So, biofire is routinely not sent in patients of GBS.
Okay. But it helps to rule out, especially the viral infections, viral meningitis if we are suspecting. It helps in pinpointing the viral load immediately. And the report
Uh,
turnaround time is around 4 hours.
yes, absolutely true. But if you're suspecting GBS, presentation is totally different. If you're suspecting viral encephalitis, presentation would be different. So, if it's
Okay.
a classical case of GBS, classical CSF finding, generally we do not send biofire.
Yes. Okay. So, Max, we proceeded with the LPs, but
Right.
we didn't do any cranial imaging in this case. So,
Hmm.
are there any things which we should be considerate about before performing a LP and without a CT scan? So,
Right.
are there any
There,
contraindications?
there are certain contraindication to immediate lumbar puncture before performing a CT scan, like presence of papilloedema, continuous or uncontrolled seizures, Glasgow Coma scale of less than 12, signs of severe sepsis or rapidly evolving rash, respiratory or cardiac compromise. If the patient is on anticoagulant therapy, antiplatelet therapy, or has a history of thrombocytopenia or any clotting abnormality, that becomes a contraindication to immediate lumbar puncture.
Okay. And based on the finding which you just presented, uh, can we have some diagnosis like it looks like a bacterial meningitis or viral meningitis, although biofire came negative?
As per the CSF report, it looks like a viral meningitis because uh, there is pleocytosis is definitely there, because the counts are less than 1,000, and there is predominance of lymphocytes.
Okay. So, man, you are convinced with the diagnosis, like we should be now thinking
Yes,
in favor of viral
yes,
meningitis.
definitely. It looks like viral meningitis only because protein elevation is also not so much as we get in bacterial.
Okay. And the
So
sugar was
with
also
these,
normal. Sugar was
sugar was also
yeah.
normal. So lymphocytic pleocytosis and proteins not in that range of bacterial, and all these findings were consistent with viral meningitis.
Okay. Okay. So, going ahead with the case.
On day one, patient was getting restless, irritable, and drowsy. So we performed a NCCT scan, which was suggestive of bulky and hypodense left basal ganglia with mild hypodensity in the right basal ganglia.
So, here, important thing was that MRI has been attempted previously, outside, but since the patient was getting restless and irritable, MRI was not possible. And we just got a CT scan done to rule out something major which was happening. Going ahead.
On day two, in view of fluctuating sensorium and CSF findings, which were suggestive of viral meningitis, so ceftriaxone and acyclovir were also started. On day three, an MRI of the brain was scheduled. However, due to the patient restlessness, irritability, drowsiness, and pooling of secretion, the MRI couldn't be completed without sedation. So it was decided to proceed with elective intubation to facilitate successful MRI. The patient was kept intubated post MRI in view of poor gag reflex.
Okay. And these were the MRI findings which we got.
So CMRI reveals uh, symmetrical T2 and FLAIR MRI revealed hyperintensities in bilateral basal ganglia. And
Okay.
of the spine, mild meningeal enhancement of the conus medullaris and mild diffuse enhancement of the cauda equina nerve root is seen. This may be related to immune mediated polyradiculopathy or viral etiology.
Okay. So based on the MRI finding of bilateral like basal ganglia involvement, now our plan changed. So what were we thinking? So can you enumerate the differentials as the differentials changed now? Are
Sure,
we thinking some other line?
sure. Based on MRI differentials for bilateral basal ganglia involvement, there can be certain possibilities like Japanese encephalitis, dengue, rabies encephalitis, or autoimmune encephalitis.
Okay. This was the pictures of the. Okay. So on the radiological imaging, is it possible to differentiate if it is bacterial or viral meningitis? Can you just throw light a little bit on that?
Definitely. Bacterial meningitis, based on MRI findings, bacterial meningitis may show prominent leptomeningeal enhancement along with parenchyma changes like edema, infarcts, or abscess formation. Certain severe or chronic cases in bacterial meningitis may come up with hydrocephalus or ventriculitis, which is rare in viral meningitis. This is the figure showing pattern of meningeal enhancement in certain cases. The figure B is showing diffuse pachymeningeal enhancement. Figure C is showing diffuse leptomeningeal enhancement. And figure F is showing diffuse ependymal enhancement on MRI imagings.
Okay. So just we'll proceed with our case and diagnosis.
Later on, we did a nerve conduction study, and the findings were compound muscle action potential, sensory nerve potentials, F wave were come down to be normal in this case.
Okay. So nerve conduction study was normal.
Right.
So, ma'am, this is essentially a normal nerve conduction study which we are looking at.
This was essentially normal nerve conduction studies because what we find, like we may get normal finding in a patient of GBS. There are subtle signs which are present in GBS, like F wave impersistence or increased latency of F wave. If these are present, these may be subtle indicators that it could be a case of GBS. In these cases,
Okay.
we generally repeat NCV after 1 week. So initial NCV may be normal even in GBS, but
Okay.
definitely in this case there were many more findings in CSF and MRI, which was taking us away from GBS.
Okay. So we'll proceed with the case.
Until day 3, the patient demonstrated a GCS of E4, VT, M6 in the morning. However, a gradual decline in motor response to M5 was subsequently observed in the evening. Weakness of limb progressed to upper extremities with power of 2 by 5, which was initially 4 by 5. And on day 3, a repeat LP was done and CSF sample was sent for rabies immunology like RT-PCR and rabies virus neutralizing antibody, serum rBNNA, and Japanese encephalitis IgM antibody was also sent. An EG was also performed on day 3.
Okay. So by day three, we can see the condition of the patient is deteriorating. The quadriparesis has worsened, and patient has also become neurologically dull. Okay. So so what are we thinking now? How's the plan changed? Even the
Based on
EEG. Hmm,
right, EBG was also suggestive of novel findings with diffuse slowing of the waves, but based on clinical history of dog bite and vaccination, finding based on CSF, MRI, and NCS diagnosis was reconsidered to be either acute demyelinating encephalomyelitis, autoimmune encephalitis, vaccine induced encephalitis, or paralytic rabies.
okay, going ahead with the
On
case.
day 4, the GCS dropped to E1VT M2. So we performed a repeat MRI, which revealed no significant interval changes compared to those observed in the previous MRI on day 2. On day 5, a tracheostomy was performed.
Okay,
So
and
we
hmm,
sent our the samples to NCDC for rabies immunology, and report on anti-rabies antibody titer. We found seroconversion was found in both blood and serum, and report on hemi-nested RT-PCR was found to be negative for CSF. Japanese encephalitis virus IgM antibodies were normal. In fact, the dengue screening was also found to be negative in this case.
okay. So the NCDC report, which regarding the encephalitis, Japanese encephalitis, that came on day seventh actually, and the RT-PCR report for rabies that came on day four. So, looking at these diagnoses, I think it was communicated to the family that the seroconversion is adequate, and with the history of vaccination, they were communicated that patient was adequately covered against the rabies. Uh, However, we were like not convinced with the findings, and we delved into it further. So at this point, Mayank, how did it turn out? So are you suspecting rabies still in this patient, or with a history of immunization, now we can rule out with the adequate seroconversion that the patient does not have rabies?
Definitely, we are suspecting rabies in this patient. And here is an interesting two articles we were published in 2016 and 19, in which they reported that though the presence of specific antibodies in CSF is considered diagnostic of rabies, irrespective of the vaccination status, and antibody to rabies virus in the CSF, regardless of the immunization history, suggest a rabies virus infection. So, based on
Okay,
these two articles, this we are suspecting a rabies encephalitis in this patient.
okay. Okay. So, ma'am, your take on this because there was some
So,
confusion. I think NCTC
yes,
communicated that the patient was adequately covered,
adequately.
but our later
Yes,
communication with them, they said that if they were also convinced that if the conversion is seen in
yes,
CSF, that is indicative of rabies. So they also
yes.
communicated to us that it is rabies. So
So if we
your
look at
take on
this
that?
case,
Hmm.
if we start connecting the dots, there was history of dog bite. He presented with tingling sensation and paresthesias in the lower limb, followed by weakness, and then it was there were red flags for GBS. And when we did the CSF, that was also not suggestive of consistent with GPS. Then MRI findings, and of course then CSF, which was showing antibodies in the against rabies. So all these points, if we join all these dots, the picture was pointing towards paralytic rabies only. But definitely family was hoping against hope, so they were just trying to find out anything which was negative. So
Which
RT-PCR
is not
is
rabies.
sensitivity of RT-PCR is very low, roughly 8%. So we can't say that RT-PCR is negative, so this cannot be rabies. So another
Okay.
differential which was coming to our mind at this point in time was whether it is rabies or it is autoimmune encephalitis or vaccine-related encephalitis. So when we thought of this, as rabies is 100% fatal disease. So for rabies, we can just provide supportive treatment. But if even if there is 1% chance that this could have been autoimmune or vaccine-related encephalitis, for considering those possibilities, we continued with IVIG. We had earlier discontinued after giving 2 doses of IVIG. We continued
Okay.
IVIG and then we offered the Plex also, for which there was some resistance from family side initially, but later on they agreed and we continued Plex also for 5 days.
Okay.
Subsequently, there was no improvement, and we were also knowing that possibly this is rabies only, and they had some financial constraint, and then they
So we'll come
shifted
to that
the
one.
patient.
Yes. Yes.
Yes.
Yes. We'll come to. Okay. So, man, can you tell us something about rabies?
Yes. Rabies is a neglected zoonotic disease that is almost always fatal once symptoms appear. Estimated 60,000 human deaths annually worldwide has been reported, and over 95% of the rabies deaths occur in Asia and Africa. India contributes to approximately 35% of the global rabies. Dogs are the primary reservoir in developing countries, which are responsible for more than 99% of human transmission. Children being under 15 years are disproportionately affected. Rural communities with limited access to post exposure prophylaxis are at higher risk. And as of January 2025, there have been 33 well documented rabies survivors, and most of the recent survivors were from India. None of these patients revived. Timely administration of a full course of recommended post-exposure rabies prophylaxis regime.
Okay. So, we delved into it this further, and the 33 documented cases of rabies which have been mentioned, only one case had a reasonable outcome at 6 months, and rest all survivors had severe neurological sequelae, and they were nearly vegetative. So, what can be the clinical manifestation of rabies? Just throw light on that.
Sure. The clinical manifestation can be divided into two major forms. One may be classical or encephalitic rabies, which accounts for 80% of the cases. And the second one is the paralytic or the dumb rabies, which accounts for 20% of the cases. And they typically follow an incubation period from 1 to 3 months, but may vary from days to years. Here I have shown a slide on difference between the paralytic and encephalitis rabies. Uh, Paralytic rabies generally presents with weakness, pain, paresthesia at the bite site. It is There are ascending flaccid paralysis is seen in these patients with hypotonia and areflexia, whereas in encephalitic rabies generally hydrophobia, aerophobia with hyperactivity is seen. So, cranial nerve involvement is mostly seen in paralytic form. Seizures are almost rare in paralytic rabies. MRI brain is always suggestive of hyperintense signal changes in brainstem or spinal cord.
Okay. So, just tell about the different tests which are there to confirm a rabies and encephalitis.
There are battery of diagnostic tests for rabies. One is RT-PCR, rabies virus neutralizing antibody, immunohistochemistry, and MRI. But the gold standard is for antepartum and postmortem is direct fluorescent antibody test.
Okay. So at this point of time, I think we communicated with the NCDC. We were in the process of sending hair follicles for direct fluorescent antibody test, but what we got communicated from them is that their lab is not standardized. The test which they are performing is not standardized. So a negative test may come, which so it may not be a gold standard from their lab. And with the CSF already showing a zero conversion. This was a clear case of rabies encephalitis. But as ma'am has already mentioned, that family was hoping against hope that it is not rabies, and we were also considering other diagnoses like acute demyelinating encephalomyelitis and autoimmune encephalitis because he was a young male. He was just 37 years and with a good family and he had a good like liabilities on him. So these were the differentials which we had kept. So kindly enumerate on these things, Dr. Van.
Sure. There is always a diagnostic dilemma pertaining to these three entities: ADM, autoimmune encephalitis, and rabies, paralytic rabies, as most of them have similar CSF findings and MRI and clinical symptoms. So I will just briefly enumerate certain of them. Autoimmune encephalitis generally presents with movement disorders or psychiatric symptoms or memory deficits. And ADM generally presents with prominently encephalopathy or multifocal CNS sign, which are not seen in paralytic rabies. They present with ascending flaccid paralysis, and reflexes are almost diminished or absent in paralytic rabies, which are mostly variable in other two entities. Autonomic dysfunction is prominent or common in autoimmune encephalitis and paralytic rabies, which is may occur in ADM variety, but it is rare. CSF findings are almost similar in all the three entities, and all the three entities are diagnosed on the grounds of MRI findings. Paralytic rabies, generally brainstem or spinal cord involvement is there, and hypertense signals are received in the particularly gray matter. Relative sparing of white matter is seen in paralytic rabies, whereas in ADM, predominantly multifocal white matter involvement is seen, and in autoimmune encephalitis, medial temporal lobe involvement is seen. EEG findings are almost similar in all the three entities. Coming down to the prognosis, it is almost like fatal in paralytic rabies. Good results have been seen with entities like ADM and autoimmune encephalitis, with the treatment modalities like immunotherapy, steroids, plasmapheresis, and rituximab or plex therapy. But it is only supportive treatment is seen in paralytic rabies.
So, what is the supportive treatment in rabies? What do you mean by supportive treatment? How can we help a rabies patient? Because it is invariably fatal, as we have seen.
So the mainstay of treatment in such patients are basically supportive, like mechanical ventilation support, use of vasopressors, fluid and electrolyte management, seizure control or sedation for managing neurological complication, starting broad spectrum antibiotics and aseptic care for preventing secondary infections, early start of parenteral or enteral nutrition, strict contact precautions for health worker safety, and providing a quiet private room is highly desirable in such patients. We can treat such patients with anticholinergic for excessive salivary secretions.
And are there
There
any
are
therapies?
there are certain investigational therapies which are experimental, and mostly agents used are monoclonal antibodies, immunomodulation with high dose immunoglobulins and interferon alpha, use of broad spectrum antiviral agents like favipiravir, ribavirin, amantadine, and use of Milwaukee protocol, which is not recommended as treatment due to poor reproducibility after 2022. But antiviral agents, for while no antiviral agents have been proven effective in control studies, and no breakthroughs have been established as of now for immunomodulation therapies. So the treatment of rabies encephalitis remains extremely limited once clinical symptoms have appeared. Rabies is almost universally fatal at its stage, but supportive and experimental therapies have been explored.
Okay. So here, I would like to ask, ma'am. So we have already seen that rabies is fatal, but still, like you mentioned, that we gave a chance of plasmapheresis to the family. So your take on that and your experience in dealing with this case.
Uh, I think definitely initially we thought that it's a case of GBS, and in fact, it was referred to me by another neurologist as a case of GBS only. But
Okay.
as the case unfolded, we got to know that it is much more than GBS. It was unfolding into encephalitic illness. And when we connected the dot and we saw the MRI, we were definitely on history and clinical examination. We were quite sure that we are dealing with rabies. And as you know, that the diagnosis of rabies is mostly made on clinical examination and history. And MRI findings were also very supportive of diagnosis. And when we got the antibodies, we were almost 100% sure, but there was definitely a denial from family side. So, but as other conditions, other differentials like autoimmune encephalitis and ADM, though there were few odd features for ADM, ADM predominantly involves white matter, not the gray matter. Autoimmune encephalitis, there are few autoimmune encephalitis which can have exactly similar picture with involvement of the basal ganglia. So that was one differential that was there in my mind. And the sole purpose of continuation of IVIG and offering them the treatment with plasmapheresis was that in case it turns out to be, if we are patient is lucky enough that he has autoimmune encephalitis, so he would respond to this treatment. But we were also in the back of our mind, we were also very clear that possibly we are dealing with a case of this universally fatal disease, rabies, and we don't have much to offer to this patient.
Okay. Okay. So what was the further course of the patient, ma'am?
Uh, Patient was definitely shifted to another hospital, and he didn't survive for long, maybe
Hmm.
for 3 or 4 days after he was taken from our hospital. So that was
Okay.
expected only in this particular illness.
Okay. That was a sad end to the story, but a lot of learning
Yes,
for us. Uh,
yes.
so just to conclude that we can say that early diagnosis of paralytic rabies is crucial to prevent unnecessary treatment in the lines of GBS or the demyelinating disorders. And GBS is frequently like misdiagnosed and it has causes a dilemma with acute demyelinating encephalomyelitis, autoimmune encephalitis, and paralytic rabies should always be considered as a potential differential in case of ascending paralysis if the patient belongs to a rabies endemic region, especially India. And to facilitate early antemortem diagnosis of rabies, MRI of the brain spine should be considered along with other battery of tests which we have already indicated. So, anything else, ma'am, you would like to say on
So
this,
there,
dealing with this
there are
case?
some, yes, there are some recommendation from some societies regarding pre-exposure vaccination, especially in endemic area. I think India is one of the endemic area. I think pre-exposure vaccination should be recommended, especially to those patients, those population who is at risk. So that is one way of having better protection against rabies. And now people are talking about elimination of rabies through vaccination of dogs. I think that is one step government should take because
True.
this is the deadly disease with no treatment. So I think
Mm.
some serious consideration should be given about elimination of rabies.
Yes, yes. So, I think that's it from our and from Rural Society of India. I thank our viewers and I hope everyone who has watched this video today has gained something out of it. And do subscribe to our channel of NCSI YouTube channel for more upcoming interesting topics related to neurocritical care. I thank our expert, Dr. Jyotiwala ma'am, and Dr. Mayank, who is the speaker today, for elaborating on this case. Thank you so much. Good evening.
Thank you, Dr.
Thank you,
Varun, for
Dr.
the
Varun.
excellent moderation.
You were excellent.
Thank you, ma'am.
Thank you
Thank
so
you, ma'am. And we'll end today's session today. Thank you, everyone.
Thank you. Thank you.
Thank you.